Hello, my colleagues and my fans, to all clinicians and doctors to whom I am speaking, and also to any one of the my public fans who understand my medical language. I was talking about the organ-specific autoimmune diseases, and I already mentioned them. Now let us talk about the organ non-specific autoimmune diseases. Organ non-specific autoimmune diseases, as I mentioned, this is the second major group of autoimmune diseases, and here the body reacts against antigens in more than one tissue, that is in two or more organs or tissues in the body. That's why these organ-specific autoimmune diseases, they are rather systemic. And these are autoimmune inflammatory systemic diseases or multisystemic diseases. Again, they are autoimmune inflammatory multisystemic diseases. They induce inflammation, and this will be the pathological process which will damage the different organs and tissues affected by the immune-mediated reaction, which, as I mentioned, is usually of the type 3, that immune complex mediated with, or immune complex deposition with complement fixation and activation, resulting in the inflammation and then further destruction and damage of the tissue or organ involved. And as I mentioned, it's usually multisystemic, affecting, it's not targeting one organ or one tissue only, like in the organ-specific, which I just mentioned. By the way, the organ-specific maximum can include two at the same time, as exemplified by Schmidt's syndrome, in which there is autoantibodies directed against the thyroid, causing immune-mediated thyroiditis, and autoantibodies directed against the adrenal, causing immune-mediated adrenalitis. This immune-mediated adrenalitis and thyroiditis, which may ultimately end in hypothyroidism and hypoadrenalism, this disease with immune-mediated thyroiditis and adrenalitis, which may come concurrently or sequentially in the same individual, we call it Schmidt's syndrome. Schmidt's syndrome. So Schmidt's is an example of organ-specific in which two organs might be involved, either sequentially, that is one after the other. It may start first with thyroid and then the adrenal pathology develops, or the reverse, that starts in the adrenal and then the thyroid autoimmune pathology develops. That is sequentially or concurrently at the same time. This is called Schmidt's syndrome. Autoimmune destruction of thyroid and adrenal, as described by Professor Schmidt. That's why its name is Schmidt's syndrome. This is the maximum in organ-specific, to be two organs affected sequentially or concurrently, but in most of the cases it is only one organ or one tissue at the same time. In the organ non-specific, the most common organ non-specific systemic autoimmune inflammatory disease is systemic lupus, of course, lupus erythematosus, SLE, with all its forms. The discoid type, the systemic type, the subacute, the acute, the chronic lupus, all the categories and the variants of lupus erythematosus, they is the commonest example of organ non-specific autoimmune disease, which affects, as we all know, more women, and which causes immune-mediated inflammation and destruction of different tissues in the body, and it has different presentations, from being mild in severity, with limited affection of the skin and or the joints or the two, up to severe cases with destruction of major organs like the brain and the kidney, causing lupus cerebritis and lupus nephritis, as we all know. So it has a wide range of presentations, from mild to severe presentations in clinical practice, the lupus, and of course with variable clinical courses, acute, subacute, and chronic, with heterogeneous clinical picture and heterogeneous pathology and heterogeneous clinical presentation or clinical expression, depending on the spectrum of tissues or organs involved in the lupus erythematosus process. So this is the systemic lupus, and the organ as an example, or as a typical example of organ non-specific or systemic autoimmune disease. Systemic lupus, also rheumatoid disease, same. It is also an autoimmune disease which in its systemic form, in its limited form, we call it rheumatoid arthritis in early cases, but in its more florid inflammatory systemic form, when the autoimmune process starts to extend beyond the joints, it becomes systemic with extra articular manifestations. We call it rheumatoid disease. So in rheumatoid disease, it is rather organ non-specific systemic autoimmune disease, which starts in the joints and then proceed to involve other tissues outside of the body, other systems and organs outside the joints, and that's why we call it rheumatoid disease. So rheumatoid disease is more broader than and more severe and more florid than just being a rheumatoid arthritis. Also, the mixed connective tissue disease, the overlap of, or what we call the connective tissue overlap. We have features of rheumatoid, features of lupus, features of scleroderma in the same patient. Also, progressive sclerosis or scleroderma is another example of organ non-specific or progressive systemic sclerosis, PSS. Also, dermatomyositis and polymyositis, whether alone or in combination. Dermatopolymyositis also is another disease category, very important, which is among the organ non-specific autoimmune diseases, and also Sjogren's syndrome. And the different overlap or cocktails of these diseases, we call it the mixed connective tissue disease or connective tissue overlap syndromes. This is the what's meant by organ non-specific or systemic autoimmune diseases. Clinical presentations, as I mentioned, is variable. It is very heterogeneous group of disorders, very heterogeneous group of disorders, which present with variable clinical manifestations, general or systemic, depending on the organ or tissue involved and damaged. It might start in the skin, causing skin rashes, different types of rashes if affecting the skin, antibodies damaging the skin, or the antibodies may damage the joints, causing arthritis, or a classic in rheumatoid arthritis, or arthralgia, which is or non-erosive arthritis in systemic lupus. In rheumatoid, it is erosive arthritis. In lupus, it is non-erosive arthritis or arthralgia. So the joint affection also, and the degree of joint affection, and whether it is arthralgia or arthritis, it's variable and differs between different groups of these autoimmune systemic diseases. So joints also manifestations may present with swollen red joints or just pain in the joints. That's why we call it arthropathy. Arthropathy is a general vague term which means arthralgia or arthritis, or both together in the same patient. So we call they has arthropathic manifestations with swelling of the joint, redness of the joint, pain in the joints, deformation in the joints, etc. so joints, or the symptoms and signs may be related to other organs, to the heart. If there is affection of the myocardium in lupus, myocarditis will be tachycardia, palpitations, shortness of breathing, chest discomfort, up to gallop and heart failure due to immune myocarditis, or sometimes also cardiomyopathy in late stages of lupus or other systemic autoimmune disease. There may be pericardial effusion also in the chest. There might be interstitial fibrosis, there might be pleural effusions, there might be interstitial pneumonitis, there might be nodules in Kaplan syndrome. So the autoimmune diseases can present with variable organ manifestations depending on the organ or tissue involved by the immune-mediated reaction and inflammation. Hepatic manifestations, cardiac manifestations, pulmonary manifestations, renal manifestations, asymptomatic urinary findings, hematuria, proteinuria, or both microscopic or macroscopic, or with nephritic syndrome, or with nephrotic syndrome, or with renal failure and chronic end-stage renal disease or chronic kidney disease, and especially in lupus erythematosus, of course, because lupus is the commonest systemic autoimmune disease associated with florid renal manifestations or nephropathy up to renal failure. It is one of the causes of nephrosis, it is one of the causes of this nephrotic syndrome, one of the causes of nephritis, one of the causes of chronic renal failure, lupus and the kidney, and this is lupus nephropathy. Lupus can affect the brain, and with brain manifestations, of course, due to cerebritis, due to vasculitis of the brain, due to involvement of the brain parenchyma by the inflammatory process, by edema, by inflammatory cells, causing disruption of brain function, with encephalopathic manifestations, and maybe also in severe cases coma due to severe florid lupus cerebritis. So the clinical manifestations or presentations is variable depending on the organs and tissues involved. It is very heterogeneous, especially in the autoimmune systemic diseases, as I mentioned. So this is important to remember when we clinically evaluate a patient with possible autoimmune disease, to take thorough history, ask about different symptoms and organ symptoms, also general symptoms. Fever may be the presentation of systemic autoimmune disease. So fever, loss of weight, loss of appetite, chronic fatigue, easy fatigability, generalized weakness, lassitude. These are all general manifestations of non-specific manifestations of autoimmune disease, in addition to the organ or systemic manifestations, depending on the specific organ a pathology or involved in different individuals, which vary from patient to patient. That's why the presentation is not fixed, it's variable case to case, and we have to analyze each case individually. And we have to approach each case with suspected systemic autoimmune disease also individually. So this is in the history taking. Physical examination, we have to examine the patient thoroughly in details. General examination, the head, the neck, the skin, the eyes, the hands, the feet, edema, clapping, neck veins, thyroid gland, lymph nodes, etc. And then systemic examination, cardiac examination, pulmonary examination, abdominal examination, liver, spleen, swellings, nervous system examination, motor system, sensory system, cranial nerves, cerebellar functions, speech, walking, mental status. So the major systems should be examined: cardiopulmonary, gastrointestinal, and neurological examination, and psychological and mini-mental status examination. And then we proceed for laboratory test. The most important screening test for any patient suspicious of having autoimmune systemic disease, which, as I mentioned, more common in women, is to do what we call anti-nuclear antibody. This is the simplest screening test for autoimmune disease. You want to pick up autoimmune disease after history taking and after physical examination. Number one in laboratory is to do anti-nuclear antibody by what we call immunofluorescent assay. So immunofluorescence IFA to detect anti-nuclear antibody number one. After that, we can proceed to other tests depending on the case and the suspicious underlying disease, because the diagnostic assays for suspicious lupus is different from if we are suspecting rheumatoid, is different from progressive systemic sclerosis, and is various, different from dermatomyositis and polymyositis, different from Sjogren's syndrome, different from overlap. But the most important is do anti-nuclear antibody and do other tests for lupus, which is anti-double-stranded DNA, anti-single-stranded DNA, the anti-Smith antibody, also the lupus band test, and then other tests like for rheumatoid, like anti-citrulline antibody after Rose-Waller test. Specific serology for rheumatoid, the specific serology for Sjogren, specific serology for progressive systemic sclerosis or PSS, anti-scleroderma 70, anti-centromere antibody for specific categories of progressive systemic sclerosis, also the specific antibodies for dermatomyositis and polymyositis. So the serology and the details of the serology will depend on the which disease you are suspecting clinically as an autoimmune systemic in your individual case. So serology is the most important test for detection of antibodies. After number one, the screening is anti-nuclear antibody. After anti-nuclear antibody, do other tests like anti-double-stranded DNA, anti-single-stranded DNA, and the all other serological tests. And then even in some cases, we have to do what we call the ANCA antibodies with its patterns, cytoplasmic and perinuclear patterns. That's PN and C ANCA. In suspicious vasculitic syndromes, which is also another autoimmune diseases with formation of immune-mediated reaction affecting the blood vessels with all its categories: small size, medium size, large size vessels, and this will also cause immune destruction of the tissues involved by the vasculitic process in vasculitic disorders or vasculitis disorders or vasculitic syndromes, which may be also either localized or generalized or systemic in pathology and in clinical presentation. Vasculitic syndromes with all its categories and all its classifications. So, and also the antiphospholipid antibodies or the anticardiolipin antibodies, and the coagulation profile, etc., in order to detect the exact antibodies responsible for the immune-mediated or autoimmune inflammatory systemic disease. So as we see, the diagnosis of autoimmune diseases depend on serology to detect the antibodies, which are responsible for tissue inflammation and destruction. Whether this is the autoimmune systemic organ non-specific, as in lupus and rheumatoid and scleroderma, or the organ specific, as I mentioned, in Graves' thyroiditis and in vitiligo and in myasthenia gravis and in type 1 diabetes mellitus and in autoimmune adrenalitis with adrenal hyperfunction or Addison's disease. These are all examples of autoimmune diseases, organ-specific and organ-unspecific. There's a link between the organ-specific and organ-non-specific, because the same individual who has organ-specific might develop organ-non-specific autoimmune disease, or the reverse. The one with organ non-specific might get some type of organ specific also. They might develop the two either sequentially or concurrently also. That is, one after the other at different phases of his life. That's why putting the patient under observation is very important in such cases, because you might find different presentations in the same patient, different presentations at different times, and variable clinical phenotypes, or we call it subtypes, and the patient may run a rather heterogeneous course, the natural history different. So such cases, they are not straightforward, and we have to put the patient and analyze the clinical status of the patient at every stage of his medical life, to assess and manage the health status in every stage of his life according to what is going on and the pathological phenomena affecting him at every part of his life, which form the basis of the clinical expression of this pathological derangement or pathological process. So clinical presentation is very heterogeneous, very variable, even in the same patient and between different patients. Natural history, different. The biological behavior, different. But there is a link between organ-specific and, as I mentioned, an organ-non-specific diseases. I will not talk about treatment, because treatment is a book. It's treatment of every disease is different, although the basis is the same, which is the use of corticosteroids, and this is the general basics, but the details different between different diseases. The exact medications, exact doses, exact duration of time for treatment, when to start, when to stop. This is different disease to disease and patient to patient, but the general rules are to use corticosteroids and to use immunomodulating or immunosuppressant drugs after steroids to decrease the steroid dose and therefore steroid sparing effect, and to minimize the complications and side effects of steroids on the body in patients taking them for a long time, especially that these are chronic diseases which are not usually curable and will need treatment for a long time and to be put under control for a long time, because many of them are with remissions and exacerbations or intermittent course, or remissions and relapses. So we have to know when to use medicine, when to stop medicine, what is the maintenance medications, what are the medications for acute exacerbations. But the general rules, as I mentioned, are corticosteroids and immunosuppressants, especially azathioprine or Imuran or cyclophosphamide or methotrexate, or the new biologics also, which entered the medical era, role of biologics, or rituximab and other biologic pathway modifiers, which we use them in patients with systemic autoimmune organ-specific diseases. For every patient needs special approach depending on the underlying pathobiology. So treatment must be pathobiologically based rather than symptom based. The treatment, successful treatment, must be pathobiologically based. You should understand the pathobiology of the disease in every individual and tailor the treatment which attack this pathobiology rather than treating the symptoms of the disease. So the wisest approach is pathobiologically based approach, and exceptionally, and then comes later the symptom based approach. That is, we treat the symptoms, not the pathobiology or the incriminated underlying mechanism of the pathophysiologic disturbance. This is the philosophy of management of autoimmune diseases in general. I already spoke about the etiology, the pathobiology, pathogenesis, clinical presentation, and little bit about the diagnosis and general principles of management of patients with autoimmune disease. Modification of lifestyle sometimes also important. The type of food is very important. The rest, avoiding alcohol, avoiding smoking, avoiding bad habits, trying to be modest in life, sleeping well, decreasing stress, stress relief, get away from stress, clear mind, exercise within limits, focus on healthy foods, especially foods which have anti-inflammatory effects, which fight inflammation, like focus on fresh fruits, focus on fresh vegetables, focus on nuts, focus on high fiber grains, focus on monounsaturated fats, like in tuna and in nuts and in nut creams, and also sometimes polyunsaturated omega-3 and omega-6, also good for the joints and good for the to decrease the systemic inflammation. Focus on, as I mentioned, on monounsaturated fats, especially in nuts, especially in avocados, chia seeds. These are all also in onion, in garlic, legumes, all types of legumes, peas, beans, etc. Coffee and tea also. Even coffee and tea, they might improve the inflammation. Coffee is one of the good anti-inflammatory popular or popularly consumed drinks in daily life. So 1 cup of coffee may help to decrease the inflammation in many individuals. So don't forget coffee, tea, and legumes and vegetables and fruits and monounsaturated fats to fight inflammation. And as an important dietary advice, as a part of lifestyle modification in patients with systemic autoimmune diseases, organ non-specific and organ specific. So type of food is important, and other lifestyle change regarding to activity, movement, stress, sleep. These are all important in order to decrease the severity and the duration of manifestations in such inflammatory syndromes of autoimmune origin. Thank you so much and have a nice day. This is just a quick resume of autoimmune disease in clinical practice as clinical most important general clinical tips. Details vary and depending on the individual case and depend on the disease category specified in every specific individual or patient. Thank you so much and have a nice day. Professor Dr. Tarek Ali. Bye bye.